If I may, I'm now going to ask a series of questions about Urso.
Yep.
And probably what we'll do is we'll edit this into a kind of little 10, 15 minute section, or 20 minutes if we do quick fire. But have a standalone section on Urso, because I think this is really important and there's some really vital questions that have come in. So, first question, if I may. I'm scared of taking Urso because I've heard it gives some people thinning hair and weight gain. Will this happen? And if it does, is it likely to settle down or go back to normal?
Okay, so hair loss and weight gain. So a lot of people talk about hair loss. It's difficult to know the significance of it. There are reasons why people kind of lose hair, if you like. With PBC, so people are unwell for any reason can do that. Thyroid disease, they can do that. Anno Domini can do that. There is a sort of recognition that you get it with PBC patients starting Urso, and there is a danger then that people put some hair loss down to the Urso. So what do I think? Well, what do I know about hair loss? But hair loss, I think you do get a little bit of hair loss with Urso, okay? I think you do get a little bit. But it's usually not dramatic. But, it can happen. Now, weight gain, and I'll talk about, the context in a second. Now, weight gain is, again, reported. That's been published by Keith Lindor, who's a very good observer of all of this. So he reported around about a 3 pound increase in weight on average, starting with Urso. Now, there is a very good explanation. I have no explanation why Urso would cause hair loss. There is a very good explanation why Urso would cause weight gain, because remember, you're underproducing bile acids. And you need bile acids to absorb fat from your diet. And so if you give people bile acids, which is what Urso is, you're helping them to absorb fat. And so basically, PBC will help you lose weight a little bit because it runs you a little bit on the under absorption of food side. So weight gain will happen, and we do warn people about it, and in order to mitigate the effects. Now, the weight gain, I think, fundamentally with Urso, it is the extent to which the benefits versus any of these side effects, would fall. And I think, if somebody was, say, 90 with very minimally abnormal liver function tests, who had big problems, all of these, well, you could argue that the benefit is relatively low. They don't need treatment quite so much. If you are 40 with a very high alkaline phosphatase, I think it's a false economy to not take those treatments, because you're worried about, those other potential side effects. And I think the worry about these is more of an issue than the reality. So what I would do is I would look at the whole picture, and I would look at, how badly I felt I needed the treatment, if you like, based on, the risk factors and things like that. But I would always err on the side of taking it. But I think I wouldn't over worry about it. I would take Urso and see what happens. Now, for people who can't tolerate Urso, obeticholic acid is also licensed, and it is licensed for people who are intolerant of Urso. So we can use it in people who are unable to take Urso, and I've certainly used it in someone who did get, quite distressing hair loss. And I think that's a reasonable thing to do. It brings its own problems around itch, so you need to be aware of that. It never causes hair loss. It doesn't cause weight gain because of the mode of action. So there is always an alternative plan. I wouldn't tend to use obeticholic acid because of fear of weight gain. I think you're putting too much on a relatively minor issue and perhaps neglecting some of the other things. So I wouldn't be over worried about Urso the vast majority of people have no meaningful problems with it, but there is always a way. But I certainly wouldn't go to obeticholic acid because of worry about hair loss. I think it would be something you'd want to see. Would you agree with that, Robert?
Absolutely. I think it's something, particularly, if you're of a certain age, and I mean this in the most polite sense, that you're still at a point where your appearance is important. And when you're dealing with the new concept of living with PBC and look at therapies, to have this other thing hanging over you, is it a potential? Is it real? How bad is it? It does have an impact in terms of what your thinking is and how you respond to it. So I think it's important to ask these questions, but the reality tends to be more about a slight thinning than it is about a hair loss per se. So yeah, but absolutely, that's helpful. Thank you. Next question about Urso, if I may. Is it inevitable that I will get liver damage even if I respond to Urso?
Sorry, what was that? Sorry, I missed the beginning of that.
Is it inevitable that I will get liver damage even if I respond to Urso?
No. I think it's about the degree of response. So yep. I think what's at the heart of that question is, what do we mean by response? Yep. And I think that's really important. Now, I think that life is a learning experience, and we all learn. And some people, it takes longer to learn than others. When we were introducing therapies to PBC, everyone got strung out on the concept of response and non-response to Urso. Okay. So I'll be honest with people. I think this is how it arose. I think people in a way wanted to protect, became very wedded to Urso. Okay. Now, most people would think if you've got abnormal tests, then, returning to normal is the response to treatment, isn't it? I mean, when you've got diabetes, the goal of treatment is to return your sugars to the levels that people who don't have diabetes don't have. And I think in the old days, we used to look to reduce glucose, but didn't try and get it back to the normal range, and people got a lot of complications from it. So why did we kind of play down the lack of impact of Urso? It normalizes very few people. I think that was because people were wedded to it, and there were very strong advocates for it. And I think for those reasons, people were very wedded to it. But it's colored our thinking ever since, because if we still think Urso is really effective, but it doesn't return tests to normal, then we slipped into that trap with some of the other therapies that have come along. So also, we kind of moving to saying, well, if those treatments, if you don't return to normal, that's still fine, because that's fine with Urso. I think we made a mistake, and we should have had a lot of simpler thinking, and it's become a rod for our own backs. And I think there's now pretty clear-cut evidence that people who have responded to Urso fall into two groups. There are those people with normal tests who have no risk at all, and there are those people who have slightly abnormal tests, but they are within the response range, who have some residual risk of liver injury. Now, that risk is clearly a lot less than people who are responders. Of course it is. And that's clear cut. However, it's still there. And I think increasingly we're going to focus on removing that risk in people who that risk might be significant to them. Now, what risk is significant to an individual, again, goes back to the individual. My metaphorical 90-year-old, well, a 30-year risk of liver injury isn't, maybe something you need to be worried about, but if you're 40, it is. And so increasingly, we are going to be looking to have normal tests for people who need a lot of years out of their liver. So in answer to the question, if you respond to Urso in terms of having a normal set of liver function tests, we are pretty confident that if your liver is not scarred, your FibroScan is normal, and you respond with normal liver function tests, you will guarantee live a normal life with PBC. If, however, you have slightly abnormal liver function tests that are still in the response range, there is a danger that you will have a sort of grumbling level of injury and will get problems over time. But they will never be as significant as people who haven't responded.
Yep. Okay, thank you. If I haven't responded to Urso, do I just take more Urso?
Yeah, okay. So up to a point. So Urso relies on getting into your bile pool in replacing the toxic bile acids. Okay, so it relies on that getting into the system. Okay, and it takes time to do that, and it has several rounds of enrichment. So if you take an Urso tablet, it goes through your gut, gets taken up, goes back to the liver, goes round again. But on the second time around, it meets the next tablet, and so you have rounds of enrichment. Now, different people will enrich to different degrees and different doses. So no two people are the same. And obviously, the longer you take the Urso and the more you take, the more you will enrich it. But there is a law of diminishing returns, and it is pretty much impossible to get beyond about 70% Urso, even if you take vast doses for a long period of time. So probably 50% is a reasonable goal. So for most people, 15 milligrams per kilogram will give you that within about 3 months. So that's why you need that length of time, 13 to 15 milligrams per kilogram. Can you force it higher by taking a higher dose? Well, possibly, but there's a caveat. So Urso is very safe indeed, but there was a trial in PSC where very high doses actually gave increased risk of death rather than reduced. And it's thought that if you take a vast dose of Urso, it actually just clogs the whole system up and means it actually makes bile flow less. That was 25 milligrams per kilogram, and that's the reason we will go. I think there is no evidence that going beyond 15 makes a meaningful difference. We have done it on occasions in people. I think going from 13 to 15 within that band can have an effect. Certainly going from 10 to 13 will do it. But going above 15, it's the law of diminishing returns. And don't go above 20 ever because it's risk.
Okay. And when you're looking at Urso response, what would we say is a good enough response? And where are the thresholds in terms of looking at additional therapies?
Yeah. Just give us 2 seconds. There's something urgent I need to respond to.
Okay.
Whoops.
So the question that we're going to ask Dave is about Urso response in terms of what do we think the measurements are in terms of normal, above normal, but okay, and above normal and still needs additional therapies. So that's going to be the question that Dave will address in a second. So this is living proof that as well as doing this kind of work, that what we have are living, breathing, real doctors that are doing real work on top of getting us. So thank you. So in terms of Urso response, normal, what does normal mean? And when should we be looking at adding on second therapies?
Okay. So what's normal in any test? So normal in any test is done by taking 1,000 healthy volunteers and measuring that test in those 1,000 people. And you will get a distribution like that. So there will be a certain value that is most frequently seen, and then you'll get a variation in values. Think of height in the population, okay? So you have some 4'10" people and 6'10" people. There aren't that many of them, but they're still normal, but most people are 5'11", okay? So it's a little bit like that. We call that a normal distribution. There is a statistical way of looking at that where we look at what are called standard deviations. So that is a measure of the distribution, okay? And standard deviations reflect the sort of variation that you see in it. And 2 standard deviations is conventionally regarded as, so a standard deviation, then another one is regarded as the standard for being an outlier to what's normal. Now that's a statistical convention. It's not handed down on tablets from on high. It's a statistical convention. What does that mean in practice? Well, for a test like alkaline phosphatase, about 2.5% of the population will be normal and have a value above the mean plus 2 standard deviations, and about 2.5% will have it below the mean minus 2 standard deviations, right? So that's 5% of totally normal people will be abnormal. And that's really important to remember, because if you have 20 tests done by your doctor, statistically, one of those by chance will be abnormal even though you're normal. Never forget that. And that's why you look at panels of tests. Gamma GT is a classic example. So gamma GT is another test a little bit like alkaline phosphatase. It's just not quite as useful. Why do we use it then? Well, if you've got a slightly elevated alkaline phosphatase, you could be one of those 2.5% of people who are normal but have a slightly high value for statistical reasons. But if you also have a high alkaline phosphatase, then it suggests that they are linked mechanistically, because statistically they wouldn't be, right, at all. So it's plus or minus 2 standard deviations. So that your normal alkaline phosphatase is the mean in a healthy population plus 2 standard deviations, and that gives you a value of 130. Okay. Now, if you have an alkaline phosphatase of 140, what does that mean? Well, it could mean one of two things. One is it could mean you're completely normal, and that's just normal for you. You're 7 foot, but you're still healthy and normal. It's not an illness, it's just you're different. Your parents were tall. Because unless you've ever had your alk phos measured before, you don't know what's normal for you. So that's the first thing to say, is that any individual value on its own is difficult to interpret. Yeah, fine, if it's 1,000, it's abnormal. But if it's marginally elevated, it's difficult to know if that's normal for you. Well, the other possibility is it's very slightly elevated. In terms of what we regarded as normal, as a response, we regarded 1.67 times the upper limit of normal as the optimum thing. You were aiming with any treatment to get below that level. You were aiming to get below that level. Okay. Now, why was 1.67 times the upper limit of normal chosen? Well, again, it was based on a bit of statistical, magic sleight of hand. And realistically, it's a continuum. The higher alkaline phosphatase, the more the risk is. And it was just regarded as a reasonable cutoff. I mean, it's not scientific at all. It's rather plucked out from the air. But it's ended up with this kind of godlike status. This kind of godlike status as being the be-all and end-all. And then the French introduced 1.5 for no particular additional reasons. And this is the problem, is that these really were, sure, people with an alk phos above 1.67 times upper limit normal had a bigger risk than people below the normal range, but, it's all shades of grey. So the only really robust statistical model is the mean plus 2 standard deviations, and therefore you should really go for normal if you want to minimize risk. So it goes back to what we were saying before. Now, do you need additional therapy if you are not in the normal range or not in the response range? For the normal, if you're not within the normal range, as I said, it depends on all manner of different factors. And I think that's an individual decision. And we would talk to people about it in terms of their own personal settings, right? I've certainly had a conversation. I've had conversations with people who've got AMA and normal liver function tests, and you talk to them about the risk of that turning into PBC being relatively low, et cetera, et cetera, et cetera. And then they tell you that their mum and their grandmother both had liver transplants for PBC, right? I can tell you that this is low risk until you're blue in the face. Your family experience is this is not low risk. And that person went on to Urso, as I would have done in that same situation. So it's where guidelines are very difficult. Guidelines are the kind of scripts that all doctors work to. But, as anyone knows, a scripted comedy is funny, but improvised comedy is really funny. And so you sometimes need to not just stick to the script. You need to adapt it to the person you're seeing in front of you, like a comedian would adapt it to their audience. So there is no hard and fast rule. The rule of thumb at the moment is everyone needs an ALT phos below 1.67 times the upper limit of normal. That does leave some people at an increased risk that's meaningful because of their age, personal risk factors, etc. I think the new benchmark will be normal. I think if people reach that benchmark, then they can be very confident. But it should not be seen as a mandatory target, if you like.
Perfect. Thank you. Does Urso prevent symptoms from happening?
So the short answer is nobody knows. Nobody knows because nobody's ever watched it, because you would have to do that in a placebo-controlled trial, because obviously people develop symptoms. And if you have a population taking Urso, they develop symptoms at a certain rate. Is that different or to how PBC patients would normally develop symptoms? So you just don't know. And of course, the Urso trials were in the days when people failed to recognize, shall we say, that symptoms were important. So that's part of the journey we've all been on, that some of my predecessors and still colleagues in PBC don't really understand or appreciate the importance of symptoms. Mm-hmm. I was in a debate with somebody yesterday who was saying, but if the liver blood tests are normal with the treatment, that's all you need, isn't it? No. No. So unfortunately, all those studies were done in the days before people looked at symptoms. So now we couldn't possibly do a placebo-controlled trial. So we can't possibly do those studies, right? So now, what do I personally think? I personally think that if you control PBC well enough, early enough, and before symptoms have developed, you will stop symptoms from developing. I'm convinced of that, actually, because of our work around really aggressive treatment in early disease. So I would struggle to think of anybody who developed significant fatigue or itch who didn't have it already to some degree before we started treatment, provided they were in really early disease. Now, I can't quote you any data, I can't show you any graphs, I can't prove that, but I've probably, as a doctor, I've probably spoken to more PBC patients than anybody else in the world, because that's what I've done for all these years, and we look after 1,000+ patients. And based on that, I'm pretty convinced. And that's why I'm convinced that earlier, better treatment is the secret in PBC. That we wait to fail, that might have a knock-on effect in terms of progression of the disease. But I'm convinced it opens up the door for people developing symptoms. So I think, as I always say, early treatment of meningitis and antibiotics is good at saving people's lives, but it also stops you getting a bad headache as well. And I think earlier, better treatment is the future. So I think step one is targeting normalization, but step two is going to be earlier, better treatment to stop these issues arising in the first place.
Perfect, thank you. And my last Urso question: does Urso cause frequent bowel motions?
Yes. So its issue is bowel disturbance. Okay, bile acids cause people to get diarrhea. There is in fact a condition called bile acid diarrhea. Okay, so actually there are people who have excess production of bile acids, gives them horrendous diarrhea. And it's horrible. If you have people who've had the end of their terminal ileum removed, they've had terminal ileum removed, they don't reabsorb their bile acids. The bile acids all go into the colon. They get terrible diarrhea. Okay, so bile acids do that. So Urso is a bile acid. It causes loosening of the stool. You also get gastric disturbance. You get gastric irritation. Yep. So you get, irritated stomach. We all know what bile vomiting tastes like. You get an element of that. Now, it is the main reason why people are intolerant of Urso. Okay, so about 5% of people given OCA, obeticholic acid worldwide, have been given it because they are intolerant of Urso. So that's the lesser reason for using it. And almost all of those, 1 or 2 are hair loss, okay, but the vast majority of those are just the GI disturbance, top or bottom. They just can't tolerate it. And what we do in those situations is we try split doses and we try lower doses and build them up. We try taking it with food, for food, after food, all manner of different ways of doing it, but they just can't tolerate it. In those situations, we use obeticholic acid, and actually we don't encounter any of those problems with obeticholic acid. It's probably the bile acid load. Obeticholic acid is also a bile acid, okay, but we use it at a vastly lower dose. So we're using 1,000 milligrams of Urso. So that's 1,000 milligrams of bile acid a day. Obeticholic acid, we're using 5 milligrams. So it's 1/200th the dose. So you get much less in the way of problems. So yes, I mean, if it's upper GI discomfort, that's quite difficult. You can try antacids and things like that, but it's a chemical irritation. For loose stools, it's actually fluid being drawn into the colon. Actually, it's not irritation, it's fluid. So actually, it's fine to take loperamide or something like that. So it's easier to control than the upper GI problems, which are just a chemical irritation. It's quite difficult to get around it.
Yeah. We've often heard from patients who start Urso, and then their movements are more loose, and then that just settles down.
Yes. And that's because your body adapts, okay? So your body adapts the uptake of bile acids in the terminal ileum. And so basically the lower GI is this oncotic effect, it's the fluid effect. But if you take the bile acid back up, if you take it back up, more effectively in the small bowel, then you won't have that issue.
Yeah. Okay, perfect. Thank you.